You are welcome to my channel. Thanks for visiting. Today, I will proceed on infective endocarditis, but it's going to be solely on signs and symptoms of infective endocarditis. If you haven't listened to other previous sessions on infective endocarditis, please kindly do. Without further ado, let's go. Before going further, let me branch at an aspect of infective endocarditis, which is diagnosis. And the hallmark of that will be the presence of inflammatory changes in valvular tissue at the site of vegetation attachment. And also, there will be fever as long as there is bacteria. I have just made reference to vegetation. All physicians that will make the diagnosis of infective endocarditis will look for this vegetation. And this time around, it's not the plants, no, at the garden, on the farm, along, no, everywhere, no. The vegetation here is the unnatural or the unwanted or abnormal growth. And some will put it simply as a mass that is formed from fibrin, platelets, and bacteria, all glued together by agglutinin antibodies that is produced by the bacteria at the infection site. It is mostly found on the valves or the endothelium, and it destroys the valves, leading to a lot of troubles, including regurgitation. Let me also branch to classify signs and symptoms, although it is no longer relevant for academic purpose, particularly when I was in the medical school, it was relevant. So acute infective endocarditis with signs and symptoms occurring within days up to 6 weeks is termed as acute infective endocarditis. It is believed that it is caused by bacteria that is very virulent or fulminant, specifically Staphylococcus aureus. So it is acute when it is within days up to 6 weeks. Then what about subacute bacterial endocarditis? The signs and symptoms will be greater than 6 weeks, but less than 3 months. It is believed that this will be as a result of streptococcus. They are less virulent, and the example here will be viridans. Then the chronic infective endocarditis will be when the signs and symptoms are greater than 3 months. That is when we term it to be chronic infective endocarditis. Like I said earlier, it's no longer relevant, but for academic purpose. When I was in the medical school, it was pretty relevant. I concluded the other time, on the previous slide, that the classification into acute, subacute, or chronic is no longer relevant. Then, what is relevant? Today, it is either short incubation or long incubation as a form of classification. It is termed to be short incubation if it is less than 6 weeks, or long incubation if it is greater than 6 weeks. When there is vegetation with bacteremia and host immune system has been overpowered, then there will be signs and symptoms. So the symptoms could be fever that could be as high as 38.5 degrees Celsius, chills, flu-like symptoms, could be anorexia that will also lead to weight loss. From poor diet, we can also run to anemia. Some will come down with cough, Others could have abdominal pain. There may be dyspnea, and some will have malaise or feeling tired. Others may have headache. Some will have joint pain. Some will have muscle pain. There may be night sweats, and some will have swollen limbs or eyelids, that is edema. The symptoms may also include nausea, vomiting, and diarrhea. Others may have nasal congestion. There may be poor wound healing. Remember, I have said earlier that the hallmark will be the presence of inflammatory process at the site of vegetation, attachment to the valves or the endothelium. And if the host immune system is pretty strong, then it could overpower that. If not, there'll be signs and symptoms. So when there's decreased immunity, like in diabetes mellitus, cancer, chemotherapy, steroid, and so many other conditions, then the individual will have poor wound healing. Then some will have sore throat, and others will have, swallowing with pain, or odenophagia. Now the signs. I will start with the hand. You can see the heart from the hand, particularly in infective endocarditis, where you are likely going to find vascular and immunological phenomena. You can find genital lesions, splinter hemorrhages, ocular nose, but not specific signs here. Not specific to infective endocarditis, might be decreased capillary filling or pulp, finger clubbing, and the rest. That is not so specific, but pathognomonic and specific signs will be genuine lesions, splinter hemorrhages, ocular nose when you check the hand. Fundoscopic examination may reveal rough spots that will appear as wide center retinal hemorrhages. But that is not pathognomonic of infective endocarditis. It could be present and also could be present in other diseases as well. For example, hypertension and so on. The signs that will involve cardiovascular system will include picking a new heart murmur and features of heart failure, including arrhythmia or valvular insufficiency. Another sign which could be part of complications will be mycotic aneurysm. Ironically, it is not a fungus disease. In fact, fungus is not part of its etiology. Some actually call it bacterial or infected aneurysm. So it is microbial arteritis. It is an aneurysm formed from bacterial infection affecting the arterial wall. It is hematogenously spread, leading to dilatation of the affected arterial wall. It's resembling fleshy fungus. And that is why the person who coined the name, Williams Osler, gave it that name, mostly caused by Staphylococcus aureus, but could also be caused by Salmonella, Klebsiella, Escherichia coli, Proteus, or Yersinia. The sign that we will pick at the abdomen or gastrointestinal tract could include splenomegaly. And on the skin of the abdomen, you may pick petechiae. On the skin, petechiae, at the extremities, some could have pallor and even gangrene. While the facial region, you can pick tenderness along the facial and cheekbones. The renal system may run into renal failure with all the features of renal failure. Now, anasaka, right? And of course, kidney infarction. We can have glomerulonephritis, and so on. The central nervous system could present with intracerebral hemorrhage, and sometimes with brain abscess, with associated headache, fever, neutralizing signs, even seizures. Let's quickly go through the list of some possible complications from infective endocarditis. The topmost will be heart failure. Heart failure. When the valves are destroyed and you are faced with regurgitation, then the heart will not be able to pump enough to the rest part of the body. So heart failure. And maybe arrhythmia. Arrhythmia will also likely end up in heart failure. Then valvular insufficiency. Remember the vegetation on the endothelium or on the valve. Then the inflammatory process taking place without the help of the host immune system. Then there may be stroke, and of course there may be brain abscess. We may be faced with intracerebral hemorrhage. Then it is possible that we can have septic pulmonary embolism, particularly from the right heart going to the lungs. Okay, then we can have splenic infarction. We may also have kidney infarction leading to renal failure. Osteomyelitis is a possibility. Part of the complications will be abscess formation, but I've decided to bring it out clearly that from infective endocarditis, they can run into brain abscess, splenic abscess, or psoas abscess. In conclusion, the host immune system is the major player here. Once vegetation is formed with the help of risk factors, then whether or not we will have signs and symptoms will depend on the host immune system. With that, I've come to the end of signs and symptoms of infective endocarditis. But we cannot get the exact picture without listening to other presentations already published on infective endocarditis right here. So check my channel for all of them. Thanks for listening. Remember to share. And remember to subscribe to my channel. I appreciate it.